Welcome back, guys. We're now going to discuss the second part of chapter 19, and that's the cardiovascular physiology. And we're going to deal today with the physiology of circulation and how the different blood vessels are um, affecting circulation itself. So we're going to take a look at flow, pressure, and resistance, and these are factors that are affecting blood pressure. And we are going to pretty much find out how they are affecting blood pressure. But before we do that, we have a few terms that we would like to consider looking at. The first one is blood flow. You could see here red blood cells that are circulating uh, inside a big blood vessel. This is definitely not a capillary, so it could be an artery. So blood flow is the volume of blood that's flowing through vessels, organs, or the entire circulation at a given period, and is measured in milliliters per minute. It is the equivalent to cardiac output of the heart. Okay, and but this is actually cardiac output for the entire vascular system. On overall, it is relatively constant when we are at rest, but at any given moment, it varies from uh, individual organs and based on the needs. Blood flow pretty much would change depending on which organ is actually active and how much blood it would need at that moment. And so let's take a look at the blood pressure. Blood pressure, you can see right here to this picture right here, is the force per unit area exerted on the wall of the blood vessel by the blood itself and is expressed in millimeters of mercury pressure. Now, it's measured as a systemic arterial blood pressure in the large arteries near the heart. And so when you say that your blood pressure is 120 over 80, you're referring to the top number as the systolic pressure and the bottom number to be the diastolic pressure. The systolic pressure is the force that is applied to by the heart to open up the aortic semilunar valve, and pretty much the force is equivalent to about 120 millimeters of mercury pressure. So when the ventricles contract, there's going to be like an what do you call it, tremendous pressure that's equivalent to 120 millimeters of mercury. Okay, in order to open the um, the aortic semilunar valve, and the diastolic pressure, on the other hand, is actually the pressure that is inside the aorta at that moment, okay, pre-existing, that is keeping the aortic semilunar valve closed. So that's exactly what the left ventricle would need to push out so that the blood can actually be moved out into the systemic circulation. Open, okay, the force of the contracting left ventricle will need to empty the blood into a closed aortic semilunar valve and push it right into the aorta, which has a pre-existing pressure of blood that is in it as equivalent to 80 millimeters of mercury pressure. So the pressure gradient provides a driving force that keeps the blood moving from higher to lower pressure areas. So here you have 120 millimeters of mercury pressure. You need that much in order to move the blood into the aorta, where the pressure could have an afterload of about 80 millimeters of mercury pressure. Peripheral resistance is a measurement of the amount of friction blood encounters with the vessel walls, generally in peripheral systemic circulation. Resistance, it's a resistance to flow. Okay, this is a measure of how thick or how sticky your blood is. Okay, and it's actually the very important to consider when you are studying the physiology of circulation. And there are three important sources of resistance. You have the blood viscosity, you have total blood vessel length, and total blood vessel diameter. So, blood viscosity is the stickiness of your blood. It is uh, the formed elements, the plasma proteins all together, okay, inside that is actually in the blood, and that's making your blood sticky. The greater the viscosity, the less easily the molecules are able to slide past each other. So they're going to have a hard time moving, and therefore the resistance is greater if the viscosity of the blood is high. So the thicker your blood, the harder it is for to slide pass through. Okay, that the greater will be the resistance. Total blood vessel length is actually just the length of the vessel. And here you have the length of the vessel that is affecting resistance, because the longer the vessel, then the greater length the blood would need to pretty much travel through, and therefore there's going to be greater resistance with greater length. What do you think is the total length of blood vessel in an average adult in the human body? It's about 100,000 kilometers. That's how long our blood vessels. It's only a fun fact. But if you're a big fella and you are bigger than an average person, then your total blood vessel length would be longer than 100,000 kilometers. It could be more because the more mass you put in your body by gaining weight, the longer will be the blood vessel. Remember how your body will need to feed all of those extra mass of flesh that you have over an average adult, and therefore your blood vessels will have to form and get into the nook and crannies further out in order to feed them. Therefore, bigger people would have longer blood vessels, and bigger people having longer blood vessels would have greater resistance because of resistance to blood flow because of the longer blood vessel length. Blood vessel diameter. Okay, this would definitely have a greater influence on resistance. Now, some frequent changes in the blood vessel diameter would pretty much like increase how, would pretty much like change how a blood would pass through it. Viscosity and blood vessel length are relatively constant, but then your blood vessel diameter could change because there are several factors in the body that could make your blood vessel constrict or dilate. Therefore, it is never constant. Your viscosity is actually not going to change, not unless you change it by way of probably diet. Probably the reason why your blood is thick is because of the food that you're eating. Okay, and therefore, your blood vessel length, if you're going to lose weight and get smaller, it will change. But for as long as in a whole day, it's the same person and you're not changing anything, the only thing that's going to change will be the blood vessel diameter, because it could change dramatically and is could be acted upon by hormones. Okay, so resistance pretty much is inversely proportional, okay, with the fourth power of the vessel radius. If the radius increases, the resistance would decrease, okay, and vice versa. If the radius is doubled, resistance will drop up to about 1/16 as much, okay. So, small diameter arterioles are the major determinants of peripheral resistance, because the small vessel diameter, I mean, arterioles are the ones that can actually abruptly respond to hormones so that they can constrict or dilate. So uh, think of think of how vasoconstriction and vasodilation will affect the flow of blood inside these diameters by imagining, let's say, your blood being this milkshake, okay? And you are either going to use the narrow straw or the wide straw to finish this milkshake. Which particular diameter would make it easier for you to finish the shake better. Of course, it's actually the white straw because there's less resistance to the flow of the very thick milkshake. So, what's the relationship between blood flow, blood pressure, and resistance? Well, the resistance is pretty much, well, for blood flow and pressure, it's actually directly proportional. So blood flow is directly proportional to the hydrostatic pressure gradient. Okay, what is a gradient? A gradient is a change in pressure. As a matter of fact, that delta sign is a sign that means change, a change in pressure. If the change in pressure is increasing, then the blood flow will speed up. Okay. Now, blood flow is inversely proportional to peripheral resistance. If the peripheral resistance is high or if it is increasing, then blood flow will decrease. And how would you increase peripheral resistance? Well, if your blood is sticky and thicker, then it would have there's going to be a lot of resistance, then blood flow would decrease. Okay? Now, resistance is more important in influencing local blood flow because it is easily changed by altering the blood vessel diameter. And the blood vessel diameter could easily be changed um, by the effects of hormones, by our emotions and our daily activities. Now, here's actually a graph showing the systemic blood pressure and the pressure of blood in the different blood vessels. Take note that the pump is actually located in this area here. Okay, and in the aorta, immediately after the blood gets into the aorta, the pressure is actually the greatest here, and you could see that the aortic pressure is the greatest, and it's actually the one moving the blood into the large arteries, then into the small arteries, and then the pressure is diminished, and then it's going to be diminished until it gets into the veins. Okay, and when it gets into the veins, the pressure is almost like negligible, and the only thing that is going to deliver the blood back to the heart will be the milking effect of the movements of the muscles around these veins. And then the pressure pretty much goes right back up a little bit and higher from the heart going into the pulmonary arteries because then again the right ventricle will pump the blood into the arteries, and that would create pressure. So here's actually only a graph showing where the pressure of the blood is actually getting higher. So blood pressure is determined by two factors. It is determined by elasticity, okay, of arteries that is closest to the heart. And it's also determined by the volume of blood that is forced into them at any given time. Blood pressure near the heart is usually pulsatile. And by pulsatile, we mean that um, the pressure is actually changing. It could increase because the blood is all of a sudden being delivered into the big arteries by the gush of blood being pumped into it by the left ventricle. And because the big arteries are elastic, they can pretty much like expand, okay, and then they go back and go back to its original size whenever the pressure drops, and therefore it is pulsatile. It is actually changing with the pressure that is generated by the pumping heart. It rises and falls with each heartbeat. Okay, so here's again a discussion of the systolic blood pressure. It's the pressure exerted in the aorta during ventricular contraction. The left ventricle pumps blood into the aorta and it imparts kinetic energy that stretches the aorta. And the average pressure is actually about 120 millimeters of mercury pressure in the adult And this is exactly the possibly the pressure that could open the aortic semilunar valve. The diastolic pressure is the lowest level of aortic pressure when the heart is at rest. So, when heart is at rest, here, this is actually your ventricles in diastole, and it's not pumping. Then the pressure inside your arteries will be the diastolic pressure. It is actually the amount of blood or the pressure that is exerted by the amount of blood that is left right there in the artery. Pulse pressure is the difference between the systolic and the diastolic pressure. Pulse itself is the throbbing of arteries due to the difference in pulse pressures, which can be felt under the skin. And you have many pulse sites, and these pulse sites are arteries that are located closer to the skin, to the skin area, and you can actually feel how it's actually pulsating. So the most popular among the pulse sites will be your radial pulse. Okay, and pretty much that's exactly how healthcare providers could manually give you or count the number of beats in or your heart rate by taking your pulse. So, what is mean arterial pressure? Mean arterial pressure is the average arterial pressure during a cardiac cycle. Mean arterial pressure is considered to be the perfusion pressure seen by organs in the body. When we say perfusion pressure, this is actually the mean arterial pressure is actually a screening um, um, it's actually a screening um, method of determining how well your blood pressure is actually helping feed your cells. Okay? For instance, a mean arterial pressure that is greater than 60 millimeters of mercury is enough to sustain the organs of an average person. But if the mean arterial pressure is less than 60 millimeters of mercury, then the organs are not being adequately perfused, or meaning they are not adequately receiving the right amount of blood where they actually get nutrients and oxygen, and therefore they will become ischemic. So, the mean arterial pressure is calculated by adding the diastolic pressure plus one third of the pulse pressure. And this is just um, a formula, and you can get your mean arterial pressure by just plugging in the diastolic pressure and the pulse pressure, and you divide it by 3. So pulse pressure and MAP both would decline with increasing distance from the heart. Just know that if this is going to be part of your next exam in the lecture, then you are going to be given, for instance, a hypothetical situation where you have to determine the mean arterial pressure using this formula here. So let's take a look at the clinical monitoring of circulatory efficiency. How do you monitor circulatory efficiency? Well, for healthcare providers who are doing this, they take what you call the vital signs, the pulse, the blood pressure, along with respiratory rate and body temperature. These are all vital signs. These are telling us that if these counts are normal, then you're healthy. If something is wrong with the vital signs, if one of them is actually not in compliance with the normal range, then the clinician can actually go through from here and find out why it is not in compliance. Now, in taking a pulse, usually a clinician would take the quickest way, which is actually the radial pulse, which is right there, taken at the wrist by the radius, right there with where the thumb area is. And the pulse points are actually areas where arteries are close to the body, and pretty much you can compress this to stop blood flow in terms of hemorrhage when a person is hemorrhaging, or you could also use it to take, for instance, your pulse. Like for instance, when we are exercising, okay, we don't take our pressure during an exercise. When instructors say, okay, let's stop for a while, the instructor will say, let's take our pulse. We don't usually do it using our radial pulse. We can hold on to our necks and find our carotid pulse right there, and that will be the easiest way to take it. So those are only some of the pressure points. There you go. You have the rest of the other pressure pulse that is easily palpated, and not every single one of these pulse pretty much would probably be palpable for all people, but on the average, you can find it if you're just going to be like looking for it. So, blood pressure is measured indirectly by an auscultatory method using sphygmomanometer. That's actually the blood pressure instrument. Okay, you wrap it around the arm, and then you increase the pressure cuff until it exceeds the systolic pressure in the brachial artery. Then you release it slowly, and then you listen for a sound. That sound, okay, that you will first hear is what you call the Korotkov sound. The Korotkov sound is a sound of the rushing blood inside the artery, and that's exactly what you hear with the stethoscope. Okay, your systolic pressure, just like what I mentioned, is usually 120 millimeters of mercury pressure, and the diastolic pressure is normally 80 millimeters of mercury pressure. Okay, your the systolic pressure is actually the pressure that you hear when you hear first the first sound that occur when the blood starts to spark through the artery is called the systolic pressure. Now, the diastolic pressure normally is 80 millimeters of mercury pressure. Is the pressure sound. As the pressure sound disappears, the last sound that you hear is actually marked to be the diastolic pressure. And what about the capillary blood pressure? Are you able to measure that? Well, no, not necessarily, not with with a stethoscope, but capillary blood pressure it ranges from 35 millimeters of mercury at the beginning of the capillary bed to about 17 millimeters at the end of the bed. And when we discuss blood flow in the tissues, and these two variable numbers, okay, will pretty much like uh, give us an idea as to exactly how perfusion in the tissues would happen. So this event, pretty much the flow of blood in the tissue or the feeding of the tissue is reliant on the pressure gradient in the capillaries. So a low capillary pressure is desirable because high blood pressure would rupture fragile thin walled capillaries. Most capillaries are very permeable, so low pressure force would filtrate into the interstitial spaces. So let's take a look at the pressure in the veins, or the venous blood pressure. Venous blood pressure really changes very, very little during the cardiac cycle. The pressure is very low. Okay, there's only also a very small gradient, about 15 millimeters of mercury pressure. So if your veins are cut and your veins are peripheral, so when you get a small cut right through your skin, the blood that gushes out is not arterial blood. It's actually your venous blood. The pressure here is low, although it will start to bleed, but it would be different when you really have cut an artery. When you have cut an artery, the blood that's going to gush out, that's going to get out right through your skin, will be gushing out, and most of the time spurting out because of the pressure of the artery. So, if an artery is cut, it is definitely going to spurt. Now, low pressure is due to the cumulative effects of peripheral resistance. Energy of blood pressure is lost as heat during each circuit. Low pressure of the veins require adaptation to help with the venous return. Remember, one of the reasons why the pressure of the blood in the veins are very low is, well, it's farther away from the heart. It's coming from the tissues, and of course the veins are not elastic and it's expandable, and so the pressure is actually most of the time lower in the veins. So if the pressure in the veins are low, how do you return the blood back to the heart? Well, the blood from the tissues is returned back to the heart through several adaptations, okay, in moving the blood. First of all, we have what you call the muscular pump. Muscular pump is a contraction of skeletal muscle, and it creates a milking effect which draws blood back. Okay, and you could just imagine that if we are bipeds and we're constantly on our feet, if you have your muscular pump pumping the blood upward into the next level, these particular venous valves will have to close. So the presence of valves is actually an adaptation to keep your blood from going back to your legs. So it can slowly go back up towards the heart. Now, that's actually the muscular pump with, of course, the help of the valves. Now, the respiratory pump. Now, the pressure changes during our breathing. So even if we're not really moving, but because we are moving our diaphragm, which is a muscle, our the pressure changes during the breathing moves the blood towards the heart by squeezing the abdominal veins as the thoracic veins would expand. Then you have also sympathetic venoconstriction, which is if we are under the sympathetic control, the smooth muscle will constrict. And as the smooth muscles constricts, it pushes blood back towards the heart. So, maintaining blood pressure. How is blood pressure regulated? Well, maintaining blood pressure requires cooperation of major organs in the cardiovascular system, the heart, the blood vessels, and then an organ that is outside of our cardiovascular system, which will be the kidneys. And all of these are supervised by the brain. There are three main factors regulating blood pressure. That will be the cardiac output, the peripheral resistance, and the blood volume. Blood pressure varies directly with the cardiac output, with peripheral resistance, and the blood volume, which means if they vary directly, whenever one would increase, the other one would increase. Okay, so which means when cardiac output is high, blood pressure is high. When peripheral resistance is high, then blood pressure is high. When the blood volume is big, then your blood pressure is high too. That's exactly what is meant by um, direct relationship. So now these are what do you call this formulas, which pretty much you can just recall to memory whenever you have a test. And you may be encountering like formulas, and when you encounter formulas, the only thing that you have to do will be to memorize these formulas and plug in the numbers that I'm going to give you in your test. All right. This is also, I'm not going to be discussing much of this because this is part of your lab. Okay, let's move on with the regulation of blood pressure. So let's take a look at factors that can be affecting um, blood pressure itself. And there are several. You have short-term regulation, that is part of neural control, short-term regulation, that's part of the hormonal controls, and long-term regulation, which is part of the renal controls. Okay, so uh, This is actually the major factors that would increase the mean arterial pressure, and pretty much it'll tell you that an increase in stroke volume and increase in heart rate will definitely increase cardiac output. You know what cardiac output is, right? Cardiac output is stroke volume times heart rate. So when both of them are increased, you have an increase in cardiac output, and eventually it will also lead to an increase in mean arterial pressure. Now, when the diameter of the blood vessels uh, would actually decrease, and then you have an increase in blood viscosity and an increase in blood vessel length, then your total peripheral resistance would also increase. Both cardiac output and total peripheral resistance has a direct relationship with mean arterial pressure. Both of them will increase mean arterial pressure when they are increased. So let's take a look at and discuss short-term regulation, or the neural control itself. There are two main neural mechanisms that controls peripheral resistance. The mean arterial pressure is maintained by altering blood vessel diameter, which would alter resistance itself. For example, when when the volume of the blood drops, all the vessels will constrict except those that are to the heart and to the vein. When the blood volume drops, that means if you get into, let's say, an accident that would cause your blood pressure to drop. Let's say you got shot and you lost a lot of blood and you were hemorrhaging. The blood volume all of a sudden drops. The first thing that the body will do will be to constrict all blood vessels, okay, except those to the heart and to the brain, in order to maintain in order to maintain blood pressure, so that the perfusion of blood into the vital organs are would stay, okay. And if they, except for those to the heart and to the brain, because these are vital, really vital organs, you cannot really constrict the vessels there to minimize the use of blood in that area. No, you can't, because you're going to lose consciousness, or you're going to have a heart attack. But you could certainly constrict vessels going to the skin, or temporarily constrict the ones going to the stomach, in order to just maintain blood pressure, because you've lost blood. Your blood volume has dropped. Okay, so this is actually one way of controlling it, by way of your brain doing it. And another, neural mechanism is that neural mechanism can alter blood distribution to organs in response to specific demands. Whenever, whenever you are in a, for instance, whenever you are in a fight, flight, fight response, whenever you are under stress, your adrenaline is high, or you are very scared, your adrenaline is high. Probably people have, if you had been in such a situation, somebody would tell you you are ash gray because you are so afraid. You turn ash. Well, that could be true to a lot of people. They turn ash gray. They would turn ash gray because there's going to be massive vasoconstriction of blood vessels during the sympathetic response on the skin, because you don't really need really blood in perfusing your skin. You need the blood during such fight, flight, fright response in the brain and in the muscles, but not on the skin. That's why whenever we're afraid, we look like pale. Okay, that's actually one way of altering distribution of blood to organs in response to specific demands. Now, short-term regulation, okay, by neural control, operates via a reflex arc that would involve the cardiovascular center, which is the medulla, at the center of the medulla oblongata, the baroreceptors and the chemoreceptors in the carotid arteries, and the higher brain centers. The cardiovascular center is actually a cluster of sympathetic neurons that you find in the medulla oblongata. And this is your cardiac center, and is The cardiac centers are your cardio-inhibitory and cardio-acceleratory centers. We discussed this already when I lectured to you the what do you call this, the heart. Okay, so pretty much you could pretty much review the role of the cardio-inhibitory and cardio-acceleratory centers of the heart. Okay, the vasomotor center would send steady impulses via the sympathetic efferents, called the vasomotor fibers, to the blood vessels. They are the ones that cause continuous, moderate constriction, called vasomotor tone. Um, and also, the cardiovascular center receives input from baroreceptors and chemoreceptors and the higher brain center. Okay, so whenever there is a change in the pressure, blood pressure, okay, or you have baroreceptors right in the carotid arches, and these are the ones that's going to be receiving that change. And then when you have a change in, let's say, a change in the pH, is actually picked up by the chemoreceptors again in the aortic arches, and it will send the inputs to the higher brain centers. So your baroreceptor reflexes, these are baroreceptors are receptors that would determine or that could sense a change in pressure. They are, just like what I mentioned, located in the carotid sinuses, in the aortic arch, and the walls of the large arteries of the neck and the thorax. Now, for instance, if the mean arterial pressure is high, okay, then the increase in blood pressure would stimulate the baroreceptors to increase input to the vasomotor center. These would inhibit vasomotor and cardio-acceleratory centers and would stimulate the cardio-inhibitory center. And that would result in a decreased blood pressure. Now, let's move on. The resulting decrease in blood pressure can be due to two mechanisms. The first one could be because of vasodilation. Okay, because the decreased output from the vasomotor center can actually cause dilation, and arterial vasodilation would reduce peripheral resistance, and therefore, when there is a reduction in the peripheral resistance, then the mean arterial pressure will also be reduced. Now, venodilation shifts blood into the venous reservoir. It decreases venous return and cardiac output. Now, decreased cardiac output, pretty much, if there are impulses to cardiac centers that inhibit the sympathetic activity and stimulate the parasympathetic activity, it reduces heart rate and contractility. Cardiac output decrease and causes a decrease, also would cause a decrease in the mean arterial pressure. So if your mean arterial pressure is low, that means your perfusion is low. What would the body do? Well, body definitely would have to undergo reflexive vasoconstriction. And this vasoconstriction is initiated, and that would eventually increase the cardiac output and blood pressure. Okay? For instance, upon standing, the blood pressure falls and triggers your carotid sinus reflex. Okay? And here the baroreceptors, okay, that monitor the blood pressure to ensure enough blood goes to the brain. And the aortic reflex, it maintains blood pressure in the systemic circuits. So the baroreceptors really are not effective if the altered blood pressure is sustained. It becomes adapted to hypertension. So it is not triggered by elevated blood pressure levels now. So here is your baroreceptor reflexes that help maintain blood pressure homeostasis. Okay. Well, actually, it's pretty much like okay. Let's get uh, pretty much the first. It's the first the in the first in the first imbalance right here. There is actually a stimulus that would depress the blood pressure. The blood pressure drops down. Okay, the arterial blood pressure falls below the normal range. And this is going to be felt by the baroreceptor. The change in pressure is going to be picked up by the baroreceptors in the carotid sinuses and aortic arch, okay, and are inhibited. This will pretty much send a signal to the brain, and the brain now is going to cause the blood vessel to constrict. So there's going to be vasoconstriction, okay. So that's in order to go back bring back the blood pressure up. Remember that your blood pressure was down here, so it brings the blood pressure up by vasoconstriction. In the same token, if your stimulus is when your blood pressure is, you know, rising up, so you're having a hypertension, an episode of hypertension, the same token, the bioreceptors picked it up, okay? It sends information to the brain, and when the brain picks it up, then your blood vessels will dilate, okay? Bringing back your blood pressure to normal range, okay? So let's take a look at the short-term regulation also. I mean, another short-term regulation, which is chemoreceptor reflex. So what are the chemoreceptors? Well, on the same spots, quite close to the where you find the baroreceptors in the aortic arch and large arteries of the neck, okay, and in the carotid sinuses, you find also specialized cells that can detect an increase in carbon dioxide or a drop in pH or oxygen level. Okay. Uh, Pretty much, if there is actually um, um, an increase in any one of that, it can cause increased blood pressure by signaling the cardio acceleratory center to increase the cardiac output, or signaling the vasomotor center to increase vasoconstriction. Okay, now why is it that there's going to be pretty much like an increase? Well, it's not only an increase in blood pressure, okay, but also an increase in our breathing rate. Okay, whenever there is actually like an increased carbon dioxide level or a drop in the oxygen level, uh, the chemoreceptors will feel it by the change in pH of the blood, or um, because it would want you to be breathing more, uh, so that you can actually breathe out the carbon dioxide and breathe in more oxygen. Besides the change in pressure. So let's take a look at the influence of higher brain centers in short-term regulation. Well, reflexes that regulate blood pressure is found in the medulla oblongata. The hypothalamus also, though, and the cerebral cortex can modify blood pressure and relays you to the medulla. The hypothalamus would increase blood pressure during stress. The hypothalamus also mediates redistribution of blood flow during exercise and changes in body temperature. Now, let's get to the short-term mechanism, which is the hormonal control. Well, the many hormones that affect blood pressure, okay, short term via changes in peripheral resistance or changes in the blood volume. For instance, your epinephrine and norepinephrine. These are hormones produced by the medullary area of the adrenal gland. Okay, they promote or they increase cardiac output and vasoconstriction. Angiotensin 2, okay, is actually stimulating vasoconstriction, and you'll find out later on in the week today that angiotensin 2 is a belongs to the production of angiotensin 2 belongs to a pathway, okay, which we call the renin angiotensin system that is pretty much controlling blood pressure. And the organs that play a role here is not only the cardiovascular system. You have the kidneys and you have the lungs that is playing a role in the renin angiotensin system. Then you have another hormone which you call the antidiuretic hormone. High levels of this can actually cause vasoconstriction. And you have your ANP, which is your atrial natriuretic peptide. Among all the hormones that are mentioned here, the ANP is the only one that would decrease blood pressure by antagonizing aldosterone, causing a decreased blood volume. All of this, okay, would increase blood pressure. Epinephrine and norepinephrine, angiotensin, the antidiuretic hormone, they all promote vasoconstriction and would increase blood pressure. The only one that would decrease the blood pressure is the atrial natriuretic peptide because it is antagonistic to the effect of aldosterone. Okay, guys, I just included this particular very good cheat sheet. I call it. It's a very good studying. It has very good information, so you could study the effects of hormones on blood pressure. Okay. Okay, now let's take a look at the renal regulation. Renal regulation is the long-term mechanism. The first two is actually just a short-term mechanism. The long-term mechanism is actually picked up by the renal regulation. Here, the baroreceptors that are found in the carotid sinuses and elsewhere quickly adapt to chronic high or low blood pressure. So if your blood pressure is chronically high, it adapts to it and it does not read it anymore. So they are ineffective for long-term regulation. Long-term mechanism can control blood pressure by altering blood volume via the kidneys. So if your baroreceptors adapt to your consistently high blood pressure and it does not react anymore, then you are going to end up having consistently high blood pressure without your body doing something about it to lower it down. Now that's not really very good because you can lose your kidney in in a few years. So the kidneys actually is very important in regulating arterial blood pressure. It regulates it via the directly by the direct renal mechanism, and indirectly by the renin angiotensin aldosterone mechanism. So let's take a look at the direct renal mechanism. The direct renal mechanism alters blood volume, that's independently of hormones. Okay, for instance, increased blood pressure or blood volume causes elimination of more urine. So this is just something like you have more blood, then because you've taken a lot of water, then you go to the bathroom frequently. Okay, so that the blood pressure is reduced. Now, decreased blood pressure or blood volume can cause the kidney to conserve water, and so the blood pressure will be increased. That's why if you're not drinking too much water, then you're going to the bathroom less in order to maintain your adequate blood perfusion pressure. Okay, so your direct renal mechanism has only got something to do with how the kidneys are actually taking in and filtering water and eliminating it if there's too much of it, or retaining it when there is actually less of it, in order to maintain the mean arterial pressure. Mean arterial pressure of 60 and above is actually needed in order that there will be adequate perfusion of the blood into the cells. Meanwhile, the indirect mechanism is actually via the renin, angiotensin, and aldosterone mechanism. I would like to use this more than the succeeding words in the PowerPoint, and this will pretty much like we'll pretty much like understand it better using this. Okay, uh, it looks like going from the top. Let's go to the bottom. It looks like in the bottom line here, we wanted to have an increase in mean arterial pressure. Okay, what would pretty much like what would be the reason why you need to have an increase in mean arterial pressure? It's because in the beginning you have decreased arterial pressure. A decrease in arterial pressure could be brought about by pretty much anything, maybe blood loss or something. Now that would inhibit the baroreceptors, and pretty much the result will be increased sympathetic nervous system activity. The kidneys will feel the decrease in arterial pressure, and it will release a hormone called renin. Okay, renin is only the kidney will only be producing renin if there is a decrease in arterial pressure. So you're losing blood. So once renin is around, this is now going to convert angiotensin, angiotensinogen, which is a precursor, into angiotensin 1. Once angiotensin 1 is there, it needs to be converted into angiotensin 2. Now there is an enzyme, angiotensin converting enzyme. This enzyme is produced by your lungs. It is released in the lungs and converts angiotensin 1 into angiotensin 2. Once angiotensin 2 is around, then there's going to be a series of events that could pretty much like be triggered. Angiotensin 2 can actually be stimulating the adrenal cortex to secrete aldosterone. And aldosterone is a hormone that would increase sodium reabsorption by the kidneys. So when sodium is retained, water is retained and your blood volume is increased. Remember, the beginning is decreased blood pressure, right? So we want to draw all of the important events that could make you increase your blood pressure back up. So let's go back to angiotensin 2. Angiotensin 2 can also promote the release of antidiuretic hormone by the posterior pituitary. And the effect of that will be to increase water reabsorption by the kidney. So you retain water. Then angiotensinogen or angiotensin 2 would pretty much like stimulate our thirst center in the hypothalamus. It will make us thirsty, and we are going to take in a lot of water. And the same angiotensin 2 can also promote vasoconstriction in the medium-sized arteries or the small arteries, and can increase peripheral resistance. All of this effect eventually will increase will actually totally increase mean arterial pressure. Now, this is what the body does in order that we're not going to be losing perfusion in the cells. Okay, I am not going to discuss that. I'm not going to be repeating myself. I already did this, so pretty much let's go to the summary of blood pressure regulation. So think of this, guys. The goal of blood pressure regulation is to keep the blood pressure high enough to provide adequate tissue perfusion, but not really so high that the blood vessels are going to pop. Okay, so just consider that if the blood pressure to the brain is very low and perfusion is inadequate, the person can actually lose consciousness. So, but if the blood pressure to the brain is too high, any one of the blood that's actually in the brain, okay, could pop and a person could have a stroke. So, it's just to maintain the blood pressure in all the vital organs so that there will be enough perfusion. Okay, and let's see. So let's take a look at regulation of blood pressure again. Okay, and take a look at some homeostatic this time, homeostatic imbalances in blood pressure. Okay, for instance, if there is transient elevation in blood pressure, that the blood pressure that occurs during changes in posture, physical exertion, okay, emotional upset, fever, that is really like normal. Okay, age, sex, weight, race, move, and posture may also cause the blood pressure to vary. That's part of being alive, being normal. But whenever you have hypertension, then it's actually a different story. This is now what you call sustained elevated arterial pressure, which is about 140 to out of 90 millimeters of mercury pressure. And that's actually sustained for a longer period of time. And pre-hypertension is actually, this area here is actually a pre-hypertension values. Okay, it's really elevated, but not yet to the hypertension range, most especially among the older people. Okay, but if you are young, okay, younger, okay, or in the middle age, you wouldn't want to have the sustained elevated arterial pressure for very long. You want to make sure that you know the reason why that is high. So, prolonged hypertension is a major cause of heart failure if you're not going to have it checked, vascular disease, renal failure, this is very important, and stroke. Heart must work hard during hypertension. Therefore, your myocardium will enlarge, it will weaken, and it will become flabby. And it also accelerates atherosclerosis. Primary hypertension, which is pretty much 90% of a hypertensive condition, pretty much has no underlying cause. You, there is actually no identifying cause because risk factors would include heredity, diet, obesity, okay, diabetes, stress, smoking. Okay, you cannot control it, but um, because of these things, but rather, it's not that you cannot control it. You cannot cure it, but you can control it. So the way to control it will be to lose weight if you're obese. Okay, you cannot make yourself any younger, but you can actually go on a better diet. Okay, you restrict salt, fat, and cholesterol intake. You increase your exercise, lose weight, stop smoking. Okay, and usually antihypertensive drugs will help. Secondary hypertension is less common, but it's due to something that you can identify being the cause of the hypertension. For instance, obstructed renal arteries or a kidney disease, endocrine disorders such as hyperthyroidism and Cushing syndrome. Now, the secondary hypertension can only be corrected if the primary cause is actually corrected. Okay, so you focus the treatment on the correcting the underlying cause. Once the underlying cause is corrected, the hypertension disappears. Hypotension is usually not a problem. Okay, it's not a concern of many people unless it causes inadequate blood flow to tissues. It's often associated with long life and lack of cardiovascular illness. So, hypotension, there are many different types of hypotension. The orthostatic hypertension is the temporary low blood pressure dizziness when suddenly rising from sitting or reclining position. A lot of people are really like this. Chronic hypertension is a hint of poor nutrition or a sign for Addison's disease and hypothyroidism. And acute hypotension is an important sign of circulatory shock, and there could be an underlying cause for acute hypertension, maybe loss of blood. And circulatory shock is a condition where blood vessels inadequately fill and cannot circulate blood normally. Inadequate blood flow cannot meet the tissue needs, and therefore what's going to be the next thing that the body does will be to um, pretty much like stop the cells or lower down the ability of the cells to take up nutrition and oxygen if they, and by doing that it will, you're actually going to get into a shock. Okay, so your hypovolemic shock results from large scale blood loss. Your vascular shock results from extreme vasodilation during and decreased peripheral resistance. And cardiogenic shock results when an inefficient heart cannot sustain adequate circulation. And very much we're done with this one. Thank you very much for listening. And we're going to go to the next slide after this.